Pseudoaneurysm of the carotid artery. The false aneurysm of the carotid artery is mostly iatrogenic, occurring both in connection with puncture and after carotid surgery, however, post-traumatic. Causes should also be considered, and clinical signs such as contusions or strangulation marks should be looked for. The on-call anesthesiologist from the intensive care unit contacts you after Sheldon catheter has been removed, following a failed puncture attempt under difficult resuscitation conditions. The catheter was apparently inserted into the common carotid artery. Now there is massive swelling of the neck, dyspnea. An ultrasound reveals a false aneurysm of the punctured common carotid artery. What do you recommend? Definition: bleeding or pulsatile hematoma of the carotid artery. Typical patient: multimorbid high-risk patient during induction of anesthesia. Patient in the intensive care unit, typically after resuscitation. Dialysis patient after malposition of an atrial catheter. Patient with acute renal failure and difficult placement of a Sheldon catheter. Status post-carotid surgery. If recent, suspicion of technical error or suture rupture. If longer ago, suspicious for infection. Post-traumatic. Hyperextension trauma. Suicide attempt by hanging. Violence by manual strangulation, patient with oropharyngeal carcinoma. Status post-radiation. Existing tracheostomy and erosion. Typical on-call situation. Contact from anesthesia due to cervical bleeding after puncture. Consultation from dialysis for bleeding pulsatile swelling of the neck. Patient presence to the emergency department with pulsatile cervical swelling. Sometimes present for a longer period, now painful. Polytrauma patient with severe cervical spine trauma. Diagnostics. Clinical examination. Inspection. Signs of infection. Redness. Swelling. Right arrow increased warmth. Right arrow tenderness on pressure. Open wound. Visible puncture. Surgical scar. Displaced catheter. Auscultation. Brute as an indication of an arteriovenous fistula laboratory. Blood count, anemia, leukocytosis, thrombocytopenia. Inflammatory markers. Coagulation parameters. Ultrasound. For orientation. Bleeding is usually well visualized. Surrounding structures are well accessible, e.g., internal jugular vein. CT angiography. Diagnostic tool of choice. Good visualization of source of bleeding. Aneurysm configuration. Thrombosis above and below. Active perfusion. Cerebral bleeding or ischemia. Therapy. Conservative. Indications. Small, no longer perfused aneurysm. No symptoms, especially no tenderness, no signs of compression. High surgical risk due to malignant underlying disease and limited life expectancy. Approach. Pain management. If necessary, antibiotics in case of suspected infection. Anticoagulation in case of suspected thrombosis embolization. Antiplatelet therapy in atherosclerosis, postoperative. Optimization of coagulation in case of bleeding complications. Interventional. Indications. Complication with existing stent. Symptomatic aneurysm in inoperable patient, e.g., significant soft tissue. Scarring after multiple previous surgeries, radiation, neck dissection. Approach. Implantation of a coated stent. If necessary, embolization, though with the risk of cerebral ischemia. Surgical. Indications. In case of active bleeding and signs of compression, dyspnea, dysphagia after recent puncture or carotid surgery. In case of catheter malposition in the artery and TIA or manifest cerebral stroke approach. Emergency revision and oversewing. If necessary, placement of an interposition graft. In case of catheter malposition, urgent removal and, if necessary, new placement on the contralateral side. Call the on-call service at night. In case of carotid complications, always call and inform. Signs of compression. Trachea can very quickly lead to life-threatening situations. Tips and tricks. Remember neuromonitoring during surgical preparation. Visualize the great saphenous vein by ultrasound, suitable for grafting. History of great saphenous vein stripping. Disinfect the leg with the better-suited great saphenous vein in a sterile manner to allow harvesting if needed. Alternatively, use a synthetic interposition graft. If puncture surgery was some time ago, simple oversewing is rarely possible. In patients with malignant underlying disease and prior cervical surgery/radia, TION prefer an interventional approach, if necessary as a bridging solution. Continuation of case example. You arrange for emergency surgical management and have the patient taken to the or immediately. You also recommend prompt intubation as increasing bleed. E-ing may make this impossible in extreme cases, necessitating an emergency. Cricothyrotomy